These are my disclosures. So as Simon nicely reviewed the literature, I'm going to talk a little bit more specifically about what the etiology of AVN is for the adolescent and the young adult group. As you know, we see a lot of AVN, a lot of times from the unstable slips, fractures. I think most people will agree that's a different category, and often, if you read the literature, they will separate out the traumatic cause of AVN. And then we see quite a lot from steroid-induced AVN from chemotherapy or transplant. And at least in North America and also in countries such as France, North Africa, Italy, they'll see a lot of AVN from sickle cell disease. And then finally, idiopathic causes. The treatment option, as Simon nicely alluded to, includes some non-surgical methods. I'm going to talk more specifically about core decompression with bone marrow injection. And then for the collapsed or more of a salvage category, often people would do osteotomies. And then vascular fibular grafting, which was popularized by Dr. Urbaniak, is still being done. Again, that can be done both for pre-collapse and post-collapse treatment. And finally, arthroplasty is getting much better. So a lot of times, I think a lot of centers have become less aggressive in terms of osteotomies and more towards more minimally invasive treatment, and then end up with arthroplasty at a later stage. The literature is confusing because often people mix different stages of disease and treatment, and the outcome that they use also is quite variable. So at least I think a lot of people have settled on a technique that they feel comfortable with and stick with it rather than being more evidence-based. In terms of early treatment, obviously pre-collapse, you're really trying to prevent collapse and the development of osteoarthritis. As we all know, the location and size of the lesion is important, and you really, for pre-collapse, you really have to use MR to do your staging. For our patient group, the age of the patient is very important. Obviously, if you are in a skeletally immature state, arthroplasty is not an option. You have to do everything to try and preserve that joint as much as you can. Obviously, the size and location of the lesion is important. And I also believe the underlying etiology of AVN is important because I think sickle cell disease is very different from steroid-induced AVN from, for example, chemotherapy. And then patient expectation and life expectancy. So if you have acute leukemia and your life expectancy is uncertain, I think that's different from someone that's expected to live a normal life. So core decompression, as you know, is minimally invasive. It really doesn't affect the future arthroplasty options. And however, as Simon said, the efficacy in preventing collapse is questionable. So in most centers, they do it in the pre-collapse small lesion. So we do the multiple small core decompression technique, which was popularized in Asian countries. And there is data out there suggesting that in small lesions, so less than certainly 30% size of the femoral head, there is some efficacy in preventing collapse. Now, the bone marrow injection technique, which is an augmentation of the core decompression technique, was developed by Professor Hernigo in France. And there is a biological effect. So he has shown that in bone marrow that is the most active in terms of cellular activity, it has the best result. Hence, it's most efficacious in the sickle cell population because their bone marrow is very active from the disease itself. So the technique is it's not simply drawing peripheral blood and injecting into the core. It's actually getting a fairly large volume of bone marrow aspirated in a careful way from the iliac crest that is concentrated down to a smaller volume, whether using a centrifuge or a filtration device, and then it is injected back into the femoral head through the core decompression. It can be done as a day surgery or overnight stay. So this is just a diagram or a photo showing you that often you have to, sometimes you have to use, we usually use one single iliac crest. Sometimes you may have to use two. The critical thing is that you have to get sufficient amount of cells delivered into the femoral head for this to be effective. And then that is, intra-op, it is filtered or centrifuged to a smaller volume for injection. Most of us do a small percutaneous core decompression, and then through one of the cores, the bone marrow is injected. This is looking at Professor Herniger's data, again, in the sickle cell population, which has the highest amount of colony-forming units. The conversion to arthroplasty is only 6% in these groups. So I'm going to go through our small series that we reported on. So this is mostly an adolescent group, so under age 18. They're all osteonecrosis due to sickle cell disease, and we looked at both clinical and radiographic results. So their pain was assessed using the Children's Hospital Oakland hip evaluation, which is specifically designed to look at pain in the sickle cell population. We also looked at clinical hip range of motion. And then we carefully looked at the radiographs before and after the procedure to look at the amount of collapse using the Kerbel's angle and the amount of collapse in terms of asphericity from the ideal sphere, as well as the Steinberg staging to look at the size of the lesion in the femoral head. So in terms of pain, and this is not unusual because core decompression alone can be helpful in terms of pain. You can see pre-op, a lot of patients had very severe pain, which did go down to no pain or mild pain on follow-up. Now, in this group, a lot of patients already had some collapse. So this is an adolescent group. Again, we don't have very good options. So that's important to note. So in terms of the necrotic angle, a lot of them had fairly large necrotic angle. And when we looked at follow-up, in terms of the size of the lesion or the amount of collapse did not get worse, it did not get better as well. However, when we used the Steinberg stage to look at the character of the bone within the head, there was improvement, and this is illustrated in this case where you can see healing of the femoral head on follow-up, and that can be seen. All right. Clinically, they did improve their range of motion, both the rotation and flexion. It's important for this group there were no medical complications and no surgical complications, and two patients had revision surgery for repeat osteonecrosis. Remember, sickle cell disease is an ongoing condition, so you could actually renecrose the same femoral head. And then one patient had FAI surgery because of the asphericity of the femoral head. Now I'm going to show you the best case scenario, okay? I think if you're treating osteonecrosis, you have to be somewhat aspirational. So this is an 11-year-old with sickle cell disease, and you can see there is collapse in this femoral head. Now, for the pediatric orthopedist, you know that an 11-year-old girl, even if it's regular Perthes disease, the prognosis is poor. So I think you would agree that the natural history of this condition is poor. On the MR, there's a large part of the femoral head that is involved. So I think the natural history of this is clear. So this is at time of core decompression. So you can see one of the K-wire has been replaced with a bone marrow injection needle. You can see a crescent sign. And this is after injecting the marrow and also injecting some radio contrast. And you can see, and people assume that the bone marrow goes nowhere, but actually if you inject contrast, you can see the bone marrow going into the femoral head. So this is 1 month after injection. This is 3 months, concerning fragmentation, and this is at 6 years. So again, this is aspirational. This is the best case scenario. You can't see femoral head heal. and maintain its sphericity. Now, there are actually published randomized control studies using this technique. This is a recently published study from Iran, where they looked at pre-collapsed femoral heads. They randomized into core decompression with and without bone marrow. They were careful enough to count the number of cells in the injection. They looked at clinical outcome, and they also followed these patients with MR before and after the treatment to see what's happening in the femoral head. And what they have found is that the pain improved in both groups, but in the core decompression with bone marrow had better improvement, and also on MR, they showed an improvement in the femoral head in terms of the necrosis. Now, this is one of the first randomized study was published from Belgium, and this is a follow-up to that study, a longer-term follow-up to look at the survival of the femoral head that was randomized into core decompression alone or core decompression with bone marrow injection. And this is the survival curve without bone marrow and with bone marrow. Again, this is pre-collapse femoral heads. The same group recently did a randomized control study comparing bone marrow, core decompression with and without bone marrow, but now in heads with some collapse. A very poor prognostic group. Now, in this group, they found no benefit of the bone marrow injection. So really, this technique, in conclusion, is best for pre-collapsed osteonecrosis. It's good in that it doesn't affect future arthroplasty options. You need to have sufficient cells, sufficient marrow activity for this to be effective. And finally, I would submit that at least in the adolescent population, we do it in femoral heads with collapse because we have no other options. Thank you very much.